Good morning, everyone. Thanks for joining us. I'm Rose Champagne. I'm one of the nurse practitioners at St. Luke's Hospital in Milwaukee. And first, I just want to go through some housekeeping. I think our format today is going to be more of a discussion, and participation is great. I'm actually so happy to see so many faces instead of just names. So when you are not speaking, if you wouldn't mind, please keeping your mic on mute. And if you do have a comment or question, please do show us your face. That would be nice. If you're not comfortable with that or you don't want to speak, you can always use the chat and we'll refer to that as well. We're very excited today to have our guest speaker, Dr. Diane Meier. She's the director of the Center to Advance Palliative Care and has numerous accomplishments, professor of geriatrics and palliative care medicine, and an author of many books and papers. And my favorite is the 2008 MacArthur Genius Award. Very excited about that. So I'm going to hand it over to Diane because I'm hoping we're going to have a nice, robust discussion today.
Hi, you guys. This is so exciting for me to be here together in real time with people working on the front lines in palliative care. And I'm really excited and curious to learn about what you're experiencing, what you see as the top challenges facing us as a field at this unprecedented time. And I really hope this will be a conversation and not a one-way droning from me. So as you know, I asked Rose and Marty to send out asking you what was on your mind so that what we talk about is important to you and relevant to you today. And I got some really helpful and broad, wide-ranging questions back from you. And I sent to Marty and Rose earlier, or about 10 minutes ago, actual responses to each question, including links that I will ask Marty and Rose to send out after our conversation, because I'd rather we have a conversation than look at that right now. But suffice it to say, if you're not aware of it, Capsys COVID-19 Toolkit is free. So even if you are not a CAPC member, a huge number of resources are available for free that address a lot of the questions that you guys posed. So we hope you won't need to reinvent the wheel. So could we just start by asking everyone to either type into the chat or maybe just type into the chat one word that describes how you're feeling right now? Well, there's a lot of consistency here in what I see. So I see a lot of tired, exhausted, overwhelmed, spent, screaming, eek, sad, uncertain, befuddled, ineffective, gratitude for it being Friday, exhausted, depleted. Couple of us said hopeful. Overwhelmed, cruise control. Or so there's a majority here of people signaling that we are collectively nearing the end of our rope. And so the question is, given that reality, what is our role as palliative care clinicians and as leaders on palliative care teams to recognize that our resources are shrinking at a time when they need to be doubling and tripling? So what do we do under those circumstances? The reality is we don't have the resources we wish we had. So what do we do with the resources that we do have? Anybody have any thoughts about that?
I know one thing that our team talks about fairly frequently is, do we shore up what we're already doing well and protect that? Or is it more about quantity and making sure that we're reaching all the different areas?
Yeah, quantity and quality. Has anybody rethought, instead of trying to do what you've been doing, you know, in the before times, in the before COVID times, thinking about whether reallocation of the scarce resource that is us might be the highest and best use of a precious, ever more scarce resource? And what I mean by that is asking your organizational leadership, saying, you know, we don't have the capacity to meet all the need, to meet the need we were meeting before this pandemic, which we were already mostly exhausted and overwhelmed pre-pandemic. And now we are in pandemic and the demands are exponentially higher. So given that we don't have infinite resources, what is the most important priority for you, for our team? So we call that a CAPC mission alignment. That is recognizing that we only see the people we're called to consult on. We don't see the big picture because it's not our job, but we can ask about the big picture. So for example, at Sinai, we basically shut down the regular consult services and embedded team members in the EDs, plural, because we have 8 hospitals, in the ICU. So we had a palliative care person, whether an RN, an advanced practice provider, an MD, or a social worker, physically present at least 12 hours a day in those settings, if not more. Plus, we set up a 24/7 hotline so that if you were, you know, the lone ED doc at some community hospital in Brooklyn and you were drowning and you literally did not have time to speak to the patient or the family about what was happening and what to expect and what they wanted, you could dial one number and get an expert palliative care person at the other end of the phone and give that person the name, telephone numbers, medical record number of the patient and ask them to do the conversation and then document it in the medical record. So we ended up providing something like 1,000 telemedicine consults to our colleagues within the system over a 1 month, less than a 1 month period. We didn't have the bodies to put in those places, but we could set up a hotline. And the hotline was staffed, everybody was called upon. And, you know, social workers were key. The RNs that we have were key, but it was covered. And we met way more needs than we would have physically in person in place. So I guess what I'm saying is it time to rethink, given the strain on your resources and the risk that people will just quit or get sick, reallocating how you spend your time in a way that does the most good and makes the greatest use out of an inadequately staffed resource. Has anybody tried that?
I don't know that we've necessarily tried that, but have had to kind of change the way we do things. For one reason, if any of us need to quarantine and we're at home instead of within the hospital, you know, kind of figuring out, well, how can I be of benefit to my team remotely? But I get what you're saying, and I think that's just what we're doing is kind of the beginning stages of that.
The first step is actually meeting with somebody in the C-suite, whether it's the chief medical officer, the chief nursing officer, or the CEO and saying, we all are dealing with scarce resources in the context of overwhelming, unprecedented demand. We don't want to decide what the highest priority is for us. We want to work with you to understand where you would like us to apply our expertise. And don't be surprised if it's the ED and the ICU. And the offer of increasing your capacity through telemedicine as opposed to in-person service, you would be able to see a multiple of the numbers of patients and families you are currently serving using that technology. It's not what we usually do. It's not what we like necessarily to do, but many, many more people will get access to your expertise.
Diane, I'm Steve Rommelfanger. I'm the System Medical Director on the Wisconsin side of the Aurora program. We actually did try to set up a hotline similar to what CAPC was recommending back in kind of March, April. And we kind of struggled with how to staff that. We set up a skeleton for doing it, and ultimately we didn't have a major surge, and where our hospitals were feeling overwhelmed, and no one actually felt it was necessary to use the hotline. They would still prefer to have the palliative care boots on the ground seeing patients. We've been busier recently, but because we span so many hospitals, the hotspots vary.
Mm-hmm.
Some are hot and the emergency room might want our help, but that might be a very small palliative program that we have there. Other hospitals are doing okay, and patients are still moving through the ER. In general, they're not bottlenecking in the ER. It seems like they're getting admitted, but then the hospitalists don't have time to have goals of care discussions.
Yeah. So obviously this method of applying resources to the highest priority setting requires being incredibly nimble. Mm-hmm. And responding to the reality on the ground. So for example, at Sinai, when we started, we were trying to staff everything. There are 8 hospitals. The ones in Queens and Brooklyn were the real epicenter. I mean, they had ambulances lined up around the block. And we thought we were going to handle that by giving everybody pocket cards with scripts and for how to have these conversations, and they laughed at us. Either be here and do it or get out of my face, essentially. They were so overwhelmed, which is why we embedded real people in those settings. That when we couldn't, though, because we literally didn't have enough people, there was always the hotline. And the hotline got a huge amount of use because it was always available. And when a setting suddenly had a surge or was overwhelmed and the palliative care team is out quarantining or is sick or has quit from exhaustion, the hotline is there. And if we can take that conversation on to the distraught family at home, or even to the patient in the ED, where we need to know what they would want if they were in respiratory failure, that's a gift to our colleagues. And if not being able to do it in person doesn't make it not useful. So it sounds like you didn't have a need for the hotline on the first go around. This go around is obviously different than the first one in terms of the unrelenting rise in cases. And the unrelenting over time demands on all clinicians, and especially us, because we take care of the sickest. So given that reality, it's unrelenting, it's overwhelming, it's too much, we don't have enough capacity. What can we do with the capacity we have that will meet the needs of the greatest number while preserving our survival? So that's a different set of priorities than responding to the pager.
Diane, there's a question from Wendy Pelletier as far as what technical support you utilized for having those conversations with patients.
Yeah, in the one pager that will get sent out to you with your questions, the COVID toolkit on the Capsy website, which is a banner at the top of the website, you just click at the top, has a whole bunch of tiles on things like emotional PPE, communication skills, symptom management, and under communication skills are scripts, literally, because it's stressful. You can't remember everything you learned during your training. Use the script. And that's what we had a lot of people working the hotline who were not accustomed to leading these conversations, who use the script. And they're all based on Vital Talk teaching. They're asking about the patient as a person. They're listening more than talking. They're using phrases like, I wish. We had, the drugs that President Trump got that made him better. There's a lot of mistrust because people saw what certain public individuals got and recovered from, and they feel like they're not getting it because we're rationing, when in fact we don't have access to those treatments, but no one trusts that. So I wish and I worry, and asking questions like, what are you hoping we can accomplish for your father? If you're Vital Talk trained and you've been teaching this stuff, it comes naturally. For most of us, it doesn't. That's what's really helpful about the scripts, because it reminds us to slow down, establish a relationship, do a lot of listening. Because until that level of trust is established, you can't communicate at all with anybody. And there were a number of questions that you guys sent about families demanding futile care and house staff wanting, or colleagues wanting us to fix that. And the things that I just mentioned are incredibly effective and helpful. And those downloadable pocket card scripts are right there for free. And you can also, more importantly, is they're on your cell phone. So you can pull them up from your pocket and literally read it. And it's very helpful on the phone if you're trying to establish a relationship. There's a whole section in there on telemedicine during COVID and how to establish a bond and a relationship over the phone or by video chat. Which is not something any of us have ever learned to do or trained to do, but there is technical assistance on how to improve the quality of that interaction so that it feels meaningful.
Dr. Turkle had a comment about how we do have to be the people who are listening and teaching and supporting our colleagues. And I think that brings up this whole, sometimes, especially in the hospital that Marty and several of us work in, it is a real boots on the ground place. So when we turn into telemedicine, it is not just what the feelings are necessarily of the patients and families, but also what are our colleagues thinking when we do that. Can you speak a little about that, how we navigate that?
Yeah, it's not surprisingly similar in that it involves, if you can make eye contact, making eye contact and saying something like, this is a really rough situation. So naming the reality first, and then the person will come back and say, I don't know if I can keep doing this. Now, what's the advantage of naming what's obvious, of saying it out loud? What does that accomplish?
A sense of control or mastery. Even if you can't change the outcome, you at least know what it is. And
You make it conscious, right? It's unconscious until you ask the question. When you ask the question, it becomes conscious, and then it can be controlled, right? Not until it's conscious. Why do you think I asked you all how you were feeling at the beginning of the call? That's why. Because if you didn't get a chance to bring to consciousness the exhaustion, the fatigue, the fear and sadness, it would dominate your experience of this conversation. But you've said it, you've given it its due. You can make room in your consciousness for other, you can make bandwidth for other content. So both with patients and families and with our colleagues, enabling people to name what they are feeling is a really important support. Because until that happens, the conversation you think you're having, you're not having. Because what's dominating their inner voice is the unsaid sadness, exhaustion, fear, anger. I know this sounds like psychiatry 101, but it's palliative care 101. In the sense that it is, until we see the person we are trying to help as a fellow human being and are interested and curious in who they are and what they're feeling, we cannot connect to help. So that's where I would start. And I think just recognizing with our colleagues the absurdity of what we are all being asked to do, and the outrageous lack of leadership from government. Enables people to then stop letting that eat away at them because it's been named, and then come back to reality and say, okay, here we are. This is where we are right now. It's like a war zone. How do we allocate the inadequate resources that we have in the best way possible? So in our case, for example, we thought it was giving people pocket cards or scripts, and that was not the answer. You know, they needed us present, and unless we were present, we were useless to them in the ED and in the ICU. So we just shut down the consult services and put the bodies where the fire was burning hottest. And that was done in collaboration with leadership, and in particular, the Crisis Standards of Care Committee, which had representatives from the CMO, the CNO, critical care medicine, emergency medicine, hospital medicine. And they were the ones who came to consensus about where palliative care should be allocated. And then we just did what they said. And by the way, that did a huge amount for our reputation in the system. Because we listened to them. You know, we asked them what they thought and where they needed help. We didn't just carry on as if we knew. So now we're seen as, you know, kind of part of the team at the system level that can be relied upon when the going gets rough. And it was because of doing what we do every day in palliative care, which is asking people what's most important to them.
My guess is that that probably also took some pressure off of the teams who are doing the direct patient care, because it wasn't them having to figure it out.
Right, exactly. And it was a decision made, from the top of the organization, and a mass email went out saying, the palliative care consult service will not be available to you as it usually is, but we have a 24/7 hotline. So if you've got a cancer patient with uncontrolled pain, you can get help. You just can't get it the way you got it in the before time. So we didn't disappear. We just made our availability much more efficient. And so there was always, on the hotline, there were always, when it was at its busiest, there were 3 people that were taking calls, and there were 3 people that were their backups, so that there were 6 people at any given time who were waiting by the phone. But that sort of 4 to 6 week period of great intensity declined, and then the numbers went down. But so it was a lot of scheduling stuff to make sure it was covered.
There's a couple questions here. Number one, about platforms that you use to reach patients and families. My guess is that may be in the things that you've sent us.
Yeah, the telemedicine
Okay.
guidance. Basically, at least in New York City, many of our patients don't have broadband, don't have minutes on their devices. So one of the things we did was get somebody to donate like boxes and boxes of tablets. And we got our hospital to pay for a courier service. And the courier service dropped off tablets and identified hotspots in every zip code, because the people who most needed us were the ones least likely to have access to broadband and devices. So we compensated for that. And wealthy people were very happy to do that, to make, very practical contributions that would make all the difference in terms of contact. So that was one aspect of it. And the other thing is we did a lot of telephone as opposed to video, just because it was easier. And fortunately, we could bill for it under the public health emergency.
This is a really great question for those small programs who are maybe solo providers in an inpatient program. What are your recommendations as far as resources and how to allocate those incredibly scarce resources?
Same answer. Speak to your leadership. Speak to your leadership. And what, for example, the Health and Hospitals Corporation in New York City did, that's the public hospitals. There are like 13 of them across the 5 boroughs. They staff the hotline with people all over the country because they didn't have enough. They have a very, very understaffed palliative care capacity because they have no money. So they actually had people in California making phone calls to families in the Bronx. And so one thing that I would suggest is, if you're in one system or are in any kind of regional area, is see if you can combine forces. And some of that may require getting temporary privileges so that you can document in the EHR of another hospital. But again, temporary privileges were offered right and left during the crisis. So that way the doctor in California could document in the Bronx Lebanon Hospital EHR. And that, it was amazing the barriers that fell away. So if you're one person in a small hospital, but you know other palliative care providers in your region and could figure out how you could come together to set up an 800 number or a single number, and then how you could take turns staffing it. That's way better than trying to do it yourself. The other issue is again, talking to your C-suite. They know where the crisis points are. We don't. And
Diane, this has been amazing. And unfortunately, I'm looking at this time thing up at the top of my Zoom, which is going to cut us off in a minute 20.
oh,
I know.
oh, I didn't realize this was so short.
I know. Well,
Yeah.
exactly. I feel the same way.